Today I will talk on approach to the patient with a postnasal drip and a rhinosinusitis. Approximately 1 liter of mucus is produced by the nasal mucosa and the tracheobronchial tree every day. Normal mucociliary function ensures that mucus produced by the paranasal sinus and the nasal cavity is transported into the nasopharynx and is eventually swallowed. To become aware of the postnasal drip, the mucus characteristic need to be altered. Either excess mucus production is there, a change in mucus viscosity, or infected mucus will make the patient aware of the presence of postnasal drip. A chronic cough is defined as one that persists for more than 2 months or 8 weeks. 90% of patients with chronic cough suffer from either laryngopharyngeal reflex, bronchial asthma, or postnasal drip syndrome. So, when a patient comes with chronic cough, we should have to think of those conditions and the need to approach them systematically. The term postnasal drip syndrome is non-specific and should be rather replaced with rhinosinusitis if purulent nasal drip is found to be present. Medication should be directed at the cause of the postnasal drip rather than treating the symptoms itself. When considering the causative factors, the following diagnosis should be considered as a cause of postnasal drip: allergic, infectious, and non-allergic, non-infectious rhinitis or others. Allergic is classified as intermittent and persistent. Infectious rhinitis can be acute or chronic, or can be subacute. Other causes which are non-infectious or non-allergic is occupational, non-allergic rhinitis with eosinophilic syndromes, hormonal causes, drug-induced, irritant foods, emotional, atrophic or gastroesophageal reflex, or it can be idiopathic. Allergic rhinitis is top on the list as a cause of postnasal drip. Rhinitis is present when the patient has 2 or more of the following symptoms: blockage, rhinorrhea, itchiness, and the sneezing of the nose. Allergic rhinitis is diagnosed when the symptoms are present, and these symptoms are due to an Ig-mediated inflammatory response secondary to allergen exposure. Patients with persistent allergic rhinitis can have chronic inflammatory changes that can be misdiagnosed as chronic rhinosinusitis. When allergic rhinitis is strongly suspected based on a positive family history of atopy and symptom complex, as I mentioned above, empirical therapy should be instituted and directed at the main symptoms. Pharmacological treatment for allergic rhinitis improves itching, sneezing, discharge, nasal blockage, and impaired smells. The mainstay of treatment for allergic rhinitis is topical corticosteroids and oral antihistamines, but ipratropium bromides, topical decongestants, oral corticosteroids, and anti-leukotrienes can be used. Allergen avoidance is important, and immunotherapy is an option for selected patients with severe symptoms who fail treatment with above measures. This immunotherapy is mainly used for those who have specific cause for their allergic rhinitis. These patients not responding to therapy should be further investigated for atopy by doing skin prick tests. Skin prick tests are quick and inexpensive, but this cannot be performed if the patient is on antihistamine, those who are suffering from severe eczema and dermographism or previous anaphylaxis. Otherwise, skin prick tests are the best method to diagnose, or the quick and inexpensive method to diagnose for cause of allergic rhinitis. Non-allergic rhinitis is present if the patient suffers from 2 or more of the above mentioned symptoms of rhinitis, but without an allergic etiology. Patients are likely to have nasal disease if they suffer from more than 5 sneezes or nose blow episodes a day. So if someone is having more than 5 sneezing per day or nose blowing episodes a day, this patient is high likely suffering from some nasal disease. 34% of patients with rhinitis have a combination of allergic and non-allergic rhinitis. So there is a place where a patient can have both allergic and non-allergic rhinitis. The following etiologies must be excluded when a patient complains of a nasal symptoms which are not due to allergy or non-allergic rhinitis. From this, viral rhinitis is one of them. This is most likely a self-limiting but can occasionally lead to chronic rhinosinusitis, especially if the patient has underlying anatomical problems. The other is idiopathic or vasomotor rhinitis. This is triggered by irritants and the change in atmospheric condition. The other cause of non-allergic rhinitis can be occupational rhinitis, which is triggered by irritant or toxic compound at the workplace. The other can be hormonal rhinitis, pregnancy rhinitis due to estrogen causing vascular engorgement in the nasal cavity. Drug-induced rhinitis are there, such as aspirin, non-steroidal anti-inflammatory drugs, beta blockers, ACE inhibitors, oral contraceptives, and also xylometazoline or oxymetazoline nasal decongestant if you use them for long time, or rebound rhinitis or rhinitis medicamentosa. Others, such as food-induced, emotional-induced, chemical-induced, and smoking can cause non-allergic rhinitis. Treatment of non-allergic rhinitis is aimed at avoidance of the irritant. Topical corticosteroids are preferred where an inflammatory pathogenesis is suspected. Azelastine nasal spray is an antihistamine and a mast cell stabilizer, and it is proved to be effective for those who have non-allergic rhinitis. In a few patients who fail medical therapy and have severe nasal blockage secondary to inferior turbinate hypertrophy, surgery is an option. The third one is infective rhinitis or rhinosinusitis. The first one is allergic rhinitis. The second is non-allergic rhinitis. The third one is infective rhinitis. The term rhinosinusitis is preferred rather than rhinitis since the inflammation involves the mucosa of the nasal cavity and the paranasal sinuses. Rhinosinusitis can be classified as acute if it is less than 1 month, subacute if it is from 1 month to 3 months, recurrent acute if there is more than 4 episodes of acute rhinosinusitis in a year, chronic if it is more than 3 months, and acute exacerbation of chronic is defined as sudden worsening of chronic rhinosinusitis with return to baseline thereafter. Rhinosinusitis is a multifactorial disease, and there are many different causes for sinus ostia obstruction with resultant inflammation of the paranasal sinus mucosa. Viral rhinosinusitis is usually self-limiting, but a combination of factors may lead to a chronic situation to develop. Anatomical variation including the natural drainage pathway of the sinus, permanent damage to the cilia responsible for mucociliary clearance either by medication, pollutants, or infections, or the presence of other comorbidities. Acute bacterial rhinosinusitis usually follows an acute viral upper respiratory tract infection. Mucosal swelling leads to obstruction of the sinus ostia, resulting in a reduction in oxygen tension in the sinus, with a reduction in mucociliary transport and transudation of fluid into the paranasal sinus. Mucostasis leads to bacterial colonization, and a chronic situation can develop if ciliary action is not improved or the ostia remains obstructed. Acute bacterial sinusitis is diagnosed clinically. So the clinical diagnosis of acute bacterial sinusitis is: the first is persistent symptoms of upper respiratory tract infection, including nasal discharge and the cough for longer than 10 days without improvement. Or we can define acute bacterial sinusitis if there is severe respiratory symptoms, including temperature of more than 39 degrees Celsius and purulent nasal discharge for 3-4 consecutive days. And the third criteria to diagnose acute bacterial sinusitis is worsening symptoms, either by recurrence of symptoms after initial improvement or any symptoms of fever, nasal discharge, and daytime cough. If the symptom complex suggests acute bacterial rhinosinusitis, empirical therapy to cover the most common etiologies such as strep pneumonia and Haemophilus influenza should be given. Chronic rhinosinusitis is multifactorial disease and the diagnosis and treatment can be challenging. If chronic rhinosinusitis is suspected, nasal endoscopy is useful to determine the presence of anatomical abnormalities such as deviated nasal septum, nasal polyps, or lesions or tumors requiring further investigation. CT scans are helpful to determine response to treatment and to decide whether surgical intervention is required after optimal medical treatment. This should only be performed after 6 to 8 weeks, after 2 months after the commencement of such treatment. The treatment of chronic rhinosinusitis with polyposis also differs from that of chronic rhinosinusitis without polyposis. If polyps are visible, empirical therapy consisting of topical and systemic corticosteroids with a macrolide antibiotic can be commenced. Macrolide antibiotics have an important immunomodulatory role by down-regulating pro-inflammatory mechanisms and they are preferred antibiotics in the patients with chronic rhinosinusitis. Certain conditions are closely associated with nasal polyposis, and the patient should be assessed for asthma, cystic fibrosis, and aspirin sensitivity. Chronic rhinosinusitis is an inflammatory disease with multiple potential associated or etiology factors, and the specific organism cannot always be identified. This is all about my content. Thank you for watching.